Hey, my name is Dr. Brendan McCarthy. Welcome to my podcast. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona, and I'm coming to you from my office. We are migrating this podcast from my home, little study that I have there, and we're migrating it to the office. And I do miss my dogs. I will bring my dogs to these videos, I promise. Once this is all set up and we have our studio built out, I'm going to be doing it with the dogs. I'll bring them both. Baxter and Jabulani will be there. So you please know I have not forgotten, and they are a part of me, and I miss having them during these videos, and they were sort of my sidekicks. Before we get into today's material, we're going to go more into migraines and discussing how we can help with them. I'd like you to please take a moment and, if you have a chance, just subscribe. If you like the stuff that we're doing, if this stuff matters to you and something you find value in, please subscribe. And if it's something that you like the way that we're presenting it, press like. And if you think this will help someone, please share it. So with that said, let's get into the material. We're going to go into migraines a little bit more. And it's important. I watched when the video dropped and when the reels went out on Instagram, I saw there was a few comments that grabbed me, and I wanted to make sure I circled back and I was very clear with this. There was one woman who pointed out that her daughter did actually have a neurological condition. And I want to be clear. This is an important point, and I'm trying to word this really well for you. There has been a profound amount of failure in medicine. And the failure that's happened in medicine, there's a stack of them. There's still a lot of misogyny written into medicine and a lack of research in women. That's something that I harp on quite a bit. There's also been quite a bit of profiteering and profit-motivated treatment therapies that's caused problems. The way medicine has been managed has been more towards saving money than into really improving quality of lives. They haven't stopped saving lives. I know this, but quality of life is not being improved anymore by medicine. That's not their goal. Their goal is to just stabilize and get you on your way or save your life. That's just such a short-sighted way of approaching health, and it has failed you. Because those of you like headaches that are unexplained in their book, you fall through the cracks. PMS falls through the cracks. So many things fall through the cracks. Your quality of life diminishes because of that. So I want you to know when we approach this failure, this gap, this loss, it's really important we're not binary about it. And this is a really important thing here. Just because they have failed in this one area doesn't mean all of it's a failure. We can't throw out the baby with the bathwater. We must retain what is important and what is good, but we also have to be very, very clear about what is wrong. So when I discuss headaches and migraines, and when I say to you, and I'm going to say the word migraine more now, because migraines affect women more than men. I wanted to make sure I was as broad as possible discussing this type of pathology, but I want to be really focusing on migraines because I'm going to speak to my base. I know who you guys are. It would be really easy for me to just bash at regular medical providers for missing you. And it'd be really easy to say all the stuff they do is bad because that's what they say out there. That's what the internet is full of. That's what the influencer has out there. That's not good. You need good care. Good care includes running down those pathways to make sure this is not neurological in nature. You want your doctor to do all those other tests, other steps. And we do that in my practice. We don't just have anyone comes in with a headache and I just run down my merry way of, oh, this is probably just your estrogen. No. I practice true medicine. We do the full workup on our patients. I don't want to make the mistake and miss a neurological condition, ever. So my due diligence requires me to do good care and take all the steps necessary to ensure that I know what's going on with my patient. I don't try and pin a diagnosis on a person before they walk in the door. Or whenever someone says, I'm having headaches, I don't try and pin the diagnosis on them. I always have to be curious. So when I come into these podcasts and these episodes and I'm fired up talking about how in today's episode, the role of estrogen in migraines, I don't want you to say, okay, all migraines are estrogen related, because we miss people. We miss people. And when people are missed, it's tragic. So let's talk about what I wanted to get into today. Before I do, the patient walks into clinic one more time and they have headaches, they have migraines. I'm going to do everything possible to understand the cause. I'm going to run every lab necessary. If this looks neurological, I'm referring out. If I can find what it is, I'm going to treat it. If there's ambiguity, I cast a wider net. It's beyond my scope, I refer out. But say the patient presents and I've come to the understanding that this is estrogen induced. This has to do with her estrogen. Then I know what to do. And how I would see that is her lab work. So estrogen has a bad reputation and it's undeserved. You need estrogen. Estrogen is the essential part of everything, associated with you being feminine. It's a very important part of your identity. It's an important part, not just about the physical identity, but it's also your biology. You need estrogen for bone density. You need estrogen for healthy cholesterol. You need estrogen for neurotransmitter synthesis. You need estrogen for memory consolidation. You need estrogen across the board. It's collagen. It's all these good things. It's not just, the reproductive hormone component. There's all these other parts that it plays a role in your health. So it's not a bad thing. But as with anything in your body, when it's out of balance, that's when pathology can occur. So you see patients often having migraines associated with their periods. Now, it could be due to progesterone, and that's going to be my next episode, because progesterone is a whole other creature, and I want to get into that separately. But also could be due to estrogen. Estrogen could be triggering migraines in women. Generally, it's due to estrogen dominance, or even supraphysiological levels of estrogen, or whether they're taking oral contraceptives. Any of these things can be related to migraines. How estrogen would do this, that's important, because when estrogen is in your body normal and in balance, we're fine. But if it's too high, how would that cause migraines? If it's too low or it's fluctuating down, how would that cause migraines? That's the part we should know, because that's how we're going to understand how to treat the individual. The role estrogen plays in the production of something called monoamines, and you know them as serotonin and melatonin, is well established. Estrogen plays a role in the production of your ability to make serotonin and melatonin. The thing about serotonin production and estrogen fluctuation is, and that's often seen in people who have PMS, when there's these fluctuations of estrogen and you're super physiological, these fluctuations in estrogen will affect your ability to make serotonin. Serotonin, you see that with your mood, with depression, with PMS. When the patient has these fluctuations and the serotonin goes low, it isn't always depression, though. See, serotonin deficits are not always what we think. We're learning that from our news, or the media, when we see these advertisements, serotonin for depression. That's all we've been taught. But let me tell you, there's more. Serotonin deficits also trigger migraines. Think of this, and you can look at this up also, always, and I'll cite this in the video description. I'll put a citation in there as well. Serotonin and migraines are linked, and you sometimes you don't have to go any further than looking at this one thing. There's the triptan class of medications out there for migraines. Many of you have taken them, and the triptan class of medications are named triptan for a reason. It comes from tryptophan. So this is the thing. When you eat, and you eat food that has protein in it, hopefully there'll be tryptophan in that food. Tryptophan gets in your body and it's in circulation. Now, tryptophan is a building block for many things, but one of the things it's an important building block for is serotonin. Tryptophan will cross the blood-brain barrier, and in the brain it gets converted to serotonin, then serotonin and melatonin. So when you have a patient that has these fluctuations of estrogen, a lot of times you'll inhibit the production of serotonin. So they give you the tryptan class of medication to bypass that. In my mindset, that's not enough. That's not quite the best approach, because, again, hold on. In the clutch, to prevent pain, yes, this is not a bad medicine to use. But long term, I really should be getting a better solution on hand than giving you this tryptan class of medicine. I should be a better physician than that. So when a patient comes in with migraines and I run her lab work and I suspect this is estrogen related, I'm going to run her estrogen panel. I'm usually day 21 because that'll let me see if it's unopposed by progesterone, and I'll see how high estrogen is getting. That's usually when I like to do it. I could do it day 3 of the cycle, but let's just say it's day 21. I did the lab for her, and her estradiol, it would be 200 to 250 or maybe even 300. Okay, what else would I run? I'd run a serum serotonin panel for her. Serum serotonin. And you can run that. That is a legitimate lab to do. Serum serotonin, I get it through LabCorp. It's not the red blood cell, it's not that, but I want serum levels. It's a lot easier to pull. You don't have to refrigerate it and all the freezing it, excuse me. The way you handle it's a lot easier. And you get more consistent lab results. But serum serotonin, if the patient has that high level of estrogen and I see a low level of serotonin, I know what I'm doing. Much easier. There'll be those random people out here right now, and science-based people say, well, serum serotonin does not mean you're testing the serotonin that's in the brain. You're absolutely right. There are enough studies that show the serum serotonin is a good indicator of what you're seeing in cerebral spinal fluid as well. So you don't have to do a cerebral spinal fluid tab and get, the cerebral spinal fluid and test that for serotonin. Use the serum. That is an adequate indicator. So now we have this patient's serotonin level. We know that it's low. We know their estrogen is high. How do we treat that? When I treat serotonin deficits like this, I'll give them the precursor, which is 5-hydroxytryptophan. In the States, that is a legal supplement. You can buy the supplement, and I'll do anywhere from 1 to 300 milligrams once a day to start. The goal of that is to give them that precursor to start the process to helping them make more serotonin. Now, the reason why I don't give tryptophan is because tryptophan, even if I give them as a protein, I still have to get that tryptophan across the blood-brain barrier, and that's a slow process. If I give them 5-HTP, it's already be present. It's going to be a lot easier to transfer over. Along with that, I'm going to give her pyridoxal 5-phosphate. That's vitamin B6. And that's the active version of it that's easily taken at that high dose of 50 milligrams. If you take regular B6 at a high dose, it's not very good for you. You need to take vitamin B6 is pyridoxal 5-phosphate. And so I use 50 milligrams of that along with 1 to 300 milligrams of 5-hydroxytryptophan or 5-HTP. I use that. That's part of the protocol. That's one area there to help replenish that serotonin level and get them feeling better there. What else am I going to do? I want to help her metabolize that estrogen. Now, if her estradiol is 250 and her progesterone is below 5 on day 21, I know that she's not ovulating very well. I know there's a host of reasons why a woman doesn't ovulate very well. And this is one of those things where I need to put on my endocrine hat, and I want to understand, like, why is she not ovulating? Is this due to chronic stress? Or is it cortisol? Is this due to prolactin? I want to run a prolactin panel. So part of my job with a migraine is to see if this is due to that not ovulating, causing her to have high estrogen. And if it is, if I can ovulate, if I get her to ovulate, I'll get that balance back. I get that estrogen will go down, the progesterone will go up. So that's one way of treating it. So figuring out why she's not ovulating. What happens when she comes in, her estradiol is at 250, and her progesterone is like, 15, 20. She's having migraines. Maybe it's just that estrogen. You get that estrogen to come down naturally. Estrogen will be out of balance for a few reasons. One is, as I mentioned a moment ago, not ovulating. But 2, you don't metabolize it very well. This is the tough part. People don't like to have this conversation. We're going to have this conversation. Your body needs to have a pathway out for estradiol. Your body has to be able to metabolize it and excrete it. In order to do that, you have to have all the cofactors and the things that are essential to get it out. That's going to be like micronutrients. So you want to make sure the patient's having a healthy diet. You want to make sure the patient's taking that estradiol converted to estrone, then the estrone, which is the intermediary before it gets eliminated, that estrone can get into the liver to be detoxified. So, cruciferous vegetables, that helps. Any compound that is rich in diindolylmethane. Diindolylmethane you can also get as a supplement. So diindolylmethane is a supplement, or, broccoli or Brussels sprouts, cabbage. These things will help induce that liver detoxification of estrogen. So it'll help move estrogen down the pathway to the liver. Then you want to have, cofactors for the body's detoxification of estrogen on hand. That would be more magnesium. Vitamin B6 will be useful in here as well. Vitamin B12 and folate. These are just important components. This is not a exhaustive list here, but these are the things that I would use in that case to help them metabolize estrogen. What else? Really important is going to be fiber. So many people have a fiber deficient diet. So I want to make sure she's getting adequate fiber in her diet. These things all play a role in helping her bring that estrogen and migrate it through her body and excrete it so it doesn't sit around. That helps the body lower that estrogen level. When you do that along with 5-hydroxytryptophan and pyridoxal 5-phosphate, you get good results. You can see that working. There's one other factor I want to throw in here that's very important that I throw in that lab as well. This is a little bit of another side piece. When your estrogen is really high, one of the problems with that is that when it's at an elevated level, is that it's going to take magnesium in your bloodstream and it's going to try and migrate it into bone at a pretty high rate. Your serum levels of magnesium are a bit lower. Women have this as a problem. This is an issue that with women. We want your magnesium to be adequate always. And estrogen has that relationship where estrogen wants to use magnesium. And magnesium in the bone is what gives it that tensile strength. Meaning, calcium gives it the density, but magnesium gives it a little bit of sway. So that way, if you fall, you don't shatter your bone. The magnesium helps it have that little bit of movement, but it's still stiff. That's from calcium. So the estrogen really wants that magnesium to be in the bone for that. But also you need magnesium to detoxify estrogen. So you're using magnesium on several fronts here. And if your diet doesn't have enough magnesium in it, you're more prone to have a magnesium deficiency. This is very common in women. So the other lab I would do with them, day 21, is the red blood cell magnesium. I would test to see how much magnesium is inside the red blood cell. That is a great therapy right there. You give them magnesium, and that along with these other things that I mentioned, using treatment, the serotonin, and also helping metabolize the estrogen out of the body, that would be a good protocol. Now, the magnesium, how would you dose that? I'd say in the neighborhood of, and I know people think I'm a maniac here, but I start about 400 milligrams. I use magnesium citrate. I know there's a lot of people that say magnesium malate or magnesium glycinate, or there's 100 other types. Listen, those they have a role, and there are important things to discuss around those. Let's just say magnesium citrate. I'll probably do a podcast on the differences between all those different versions of magnesium in the future, but still, for the time being, magnesium citrate, 400 milligrams before bed. That helps with sleep. Because remember, if you're not making serotonin, as I mentioned earlier, serotonin converts to melatonin. So a lot of times people with migraines can have sleep issues as well, and that's due to melatonin deficiencies. So when you give them magnesium at 400 milligrams before bed, that will help sleep as well. What if that doesn't work though? What if they're not getting benefit? You can go up to 600 milligrams. I've even gone as high as 800 milligrams. Not beyond that though. But I've done 800 milligrams at night before bed for sleep, for preventing headaches, for migraines. In clinic, in the setting that we operate here, with a patient who presents into clinic at that time who has a migraine, we'll do a magnesium IV, push of magnesium at a slow rate. You do a slow push of magnesium. That has been shown to arrest a migraine as well. Magnesium plays a role with migraines on several fronts, but one of the important ones is that it's a smooth muscle relaxant. As a smooth muscle relaxant, it stops that spasm of the arterioles in the brain that tend to be associated with migraine. So you have that dilation, and that gets better blood flow throughout the brain. And you see also throughout the rest of the body as well. And that's a lot of times what triggers people to go on that sleep, because you dilate out those blood vessels. Everything's relaxed. The blood circulation goes all over the place. You tend to just doze off into sleep with it. So for migraines, I want you to know when a patient presents, I see estrogen dominance or excess estrogen. I'm thinking about serotonin. I'm thinking about how to get the estrogen out through the body, through digestion and then elimination. I'm thinking about the whole pathway. I'm thinking also about magnesium citrate as a therapy before bed, sometimes while they're having the migraine. This is my approach when it comes to estrogen. At the next episode, I'm going to get a little bit more into the weeds with progesterone. So the progesterone thing is it's a lot more neuroactive as progesterone. Progesterone plays a role with the GABA receptors and it plays a role with brain chemistry, but then you also have allopregnanolone, and even as we use pregnenolone as a supplement along there as well, there's a lot more we're doing with progesterone, pregnenolone in the brain, and the neuroactive steroids that they're associated with. So that'll be our next episode. I hope this helps. I did it a little bit different this time. I don't know if you noticed. I tried in one episode to talk about one specific way of treating, one different way of kind of diagnosing and how I'd approach it. I hope this is more clear when I do it this way, because I hear you when you're asking for like, what's the lab value and how, what's the dose you would do and how many milligrams and when and why. You are so valid for asking these questions, and I want to be helpful. I want to be helpful. So to the degree that it is, we're doing good. To the degree that's not helpful, your comments mean everything. We will be watching for them. Yeah. So thank you so much again for tuning in, and I will see you at the next episode.